लाइव शुरू होने हुआ देखते हैं या जी 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 वॉइस से पा रहे हैं ब्लूटूथ में जा रही है उसमें नहीं आ रहा अब आ रहा है और मैं कैसे सुनूं चलिए
A very good evening to all of you, ladies and gentlemen. With utmost delight, I, Dr. Nidhi Thakur, welcome you all to our prestigious and picturesque college, Dr. Rajendra Prasad Government Medical College, Tanda, District Kangra, Himachal Pradesh. I would like to take a moment to extend my warmest greetings to each and every one of you for making an effort to be here in this CME of Telemedicine in the Himalayas. This, being an inaugural CME, will be a sensitization for all of you for an upcoming main event which is to be held in November 2024 at Dr. RPGMC Tanda itself under the aegis of Telemedicine Society of India in collaboration with AIIMS Bilaspur, Himachal Pradesh. Nestled among the majestic peaks and verdant valleys, the Himalayas offer a breathtaking landscape. However, this very geography that captivates our souls also possesses significant challenges, particularly in healthcare delivery. The rugged terrain, isolated yet beautiful villages, and at times harsh weather conditions often make access to quality medical care a daunting task. It is here that telemedicine emerges as a beacon of hope, bridging gaps between medical professionals and people who require their expertise the most. This practice of using telecommunication technology tends to provide varied benefits for the state of Himachal Pradesh and for the other states as well. It brings specialized care to remote areas, reduces the need of arduous travel, and also supports continued medical education and training for local healthcare workers, and of course the treatment. Nevertheless, it plays a crucial role in public health initiatives. So as we progress through this event, we would be enlightened about the role of telemedicine, bridging gaps and creating opportunities. Ladies and gentlemen, with this, We shall commence our event by lighting the lamp of knowledge and wisdom. So it is my great honor to invite the principal of Dr. RPGMC Tanda, Dr. Milab Sharma, to please come on stage. Dr. R. Kim, President of Telemedicine Society of India. Dr. Sunil Shroff, Secretary, Telemedicine Society of India and Vice President. Dr. Shelly Rana, Professor and Head of the Department Anesthesia. Dr. Avninder, Additional Director, Dr. RPGMC Tanda. And Dr. Rita Dadwal to please come on stage and do the honor. And last but not the least, our very dear Dr. Jaising sir to please come on the stage and commence the event. So I have just gathered the information that Dr. Rajesh Guleri, who is CMO District Kangra, has arrived. So I request Dr. Rajesh Guleri to please come on stage and help us. As I can see, we have a beautiful audience. Please give a big round of clap, please. Now we'll commence the session with a Vandana. For that, we are having young beautiful ladies who would do this gracious performance and would keep the tradition on. I request everyone to please come on the stage.
अज्ञानता से हमें तार दे माँ, हे शारदे माँ, हे शारदे माँ। अज्ञानता से हमें तार दे माँ, तू स्वर की देवी है, संगीत तुझसे, हर शब्द तेरा है, हर गीत तुझसे। हम हैं अकेले, हम हैं अधूरे, मेरी शरण में हमें प्यार दे माँ, हे शारदे माँ, हे शारदे माँ। अज्ञान हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। तू श्वेत वर्णी कमल पे विराजे, हाथों में वीणा मुकुट सर पे साजे। अज्ञानता के मिटा दे अंधेरे, उजालों का हमको संसार दे माँ। हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ, हमें तार दे माँ, हमें तार दे माँ।
Thank you for such a wonderful performance. I request audience to please give a big round of applause to these girls, because they have spread a vibe of positivity, and we can see the beautiful audience is still here and who are going to have an amazing time here. Now I would like to invite our worthy principal, Dr. Milab Sharma, without whose support and encouragement this event would not have seen the light of the day. As a chief patron, when he was approached regarding this event, he, in spite of having a busy schedule, ensured that all the arrangements of this event completed in a very short time. So please hold the stage.
Esteemed office leaders of TSI and all the executive members of TSI, office leaders of TSI Himachal branch, and some of the office leaders might be joining offline, and those who are not present in this hall at this very moment, and my distinguished faculty members from Tanda Medical College. On behalf of this institution, I extend warm welcome to Dr. R. Kim. He is the President of TSI, National Chief. Dr. Meenu Singh, who is not there, but she is likely to join online. She is Director, All India Institute of Medical Sciences, Rishikesh. Dr. Sunil Shaw is Vice President, TSI. Dr. Rajesh Kuleri, CMO, District Kangra. Dr. Ashok Verma, Medical Superintendent, DRPGMC Tanda. Major Abdinder, he is Additional Director, Medical College Tanda. Dr. Uma Shankar, Honorary Secretary TSI. Dr. Krishan Kumar, Treasurer TSI. Dr. Shali Rana, HOD, Department of Anesthesia, Medical College Tanda. Dr. Mrs. Dadwal, she is the Vice President of TSI HP Chapter. Dr. Naresh Sharma, Honorary Secretary, HP Chapter of TSI. Dr. Shyam Bhandari, he is Joint Secretary, cum Treasurer, HP Chapter of TSI. And all my esteemed faculty members and all the delegates present here in this auditorium. This is indeed a matter of great honor and privilege for our institution that this CME is being conducted in this auditorium today. And as I have been told by Dr. Bhandari and other members of HP branch of TSI, that this is just the initial step and they are about to take a big leap when they are going to hold the international conference in this very hall in next 2 to 3 months. So that will bring our institution to international level as far as AI and telemedicine is concerned. The theme for today's CME that is very, very appropriate, keeping in view the tough terrains of Himachal Pradesh. And this very theme reminds me about 35 years back when many of my batchmates, they went for posting in Himachal Pradesh. So they got their posting in places where was no road access. And many of their posting places, they were about 10, 50 kilometers and they had to walk on foot. So no doubt none of them joined there. But when they approached the Director Health Services of that time, what he told them, you are very lucky, at least you can walk on foot. When he joined during his time, say 20, 30 years before these students, he used to go to his place of posting by swimming in the rivers. So at least you are very lucky. So anyway, that is a total different story. When I was just discussing with Dr. Kim, so So many of us, even what we feel today is the telemedicine is nothing but you can send a message, you can say communicate the condition of the patient, and as I have been told that today they will be doing some practical demonstration how you can manage a patient even in ICU and you can get consultation of different specialties. And many of the radiological investigations, they can be passed and the consultation can be had through, say, telemedicine. So what I feel today, the importance of this CME will be that it will pave a new way for this telemedicine in Himachal Pradesh. And after getting the wisdom from the experts of this field, this will be of very, very appropriate and of great help for the suffering humanity of Himachal, of other, say, hilly areas and other Himalayan states. So again, I welcome and thank all the delegates, all the office bearers of, say, Telemedicine Society of India, and say all the office bearers and those who are present here of the dais. Thank you very much.
Thank you, sir. It is my great great pleasure to now invite Dr. R. Kim for the presidential address. So please come on the stage. Sir is President Telemedicine Society of India and our chief guest.
At the outset, good evening and pranams to every one of you here, the dignitaries, the wonderful students assembled here. I really envy every one of you here for this being in this such a beautiful campus, in a beautiful place. I'm so happy to be in this auditorium, and I want to first thank our principal Milap Sharma. But for him, we wouldn't be here. And thank you, sir, for extending all the cooperation for organizing this event. When they told me that event, there is a CME happening, I was thinking of a small event and maybe about 40, 50 people sitting there. But we weren't prepared for something like this. But I'm all the more happy because we have all the youngsters here. Because you are the ones who have to know what's happening on this, because this is going to be playing a much bigger future. I'm sure many of you are experiencing it at this point of time. But going forward in this digital era, I think things are going to change how we practice medicine. So just to share a few slides here, now that I'm going to talk too much about telemedicine. Should I use this? Yeah, we know this is not something new. We know we are the biggest population in the whole world, next to China, and which means, what does it mean for us as physicians? More than 2/3 of the India's population reside in rural areas. We all know that. And the rural-urban distribution is close to 70-30%. So what does it mean for us? While India has the highest number of young people, aging population is also rapidly progressing. People are living longer, so which means the problems related to old age is also going to increase, which means it's more work for the physicians. The current elderly population of 153 million, that is 60 and above, is expected to reach a staggering 347 million in another 30 years or 25 years. So we also know that how the physicians are distributed over the country. You know, for every if you look at the physicians in the rural versus urban, it is 13 in rural and 33 in urban. And this is happening. Obstetricians, specialists are nowhere in the rural areas. Now, does it mean these people do not have access, cannot have access to care? And another factor, in most developing countries, the proven treatment are reaching, even in the urban areas, are only 20% of the people who need it. We are still not reaching 80% of it. I can say this in eye care. I am an ophthalmologist, I'm a retina specialist. So I deal with eye problems, and we know, because we do a lot of population-based studies, even in the 20% who get care, a significant number of them present themselves too late for good outcomes, which means we have to catch them early on. And also, our practice is very reactive, dealing with those who present to us and who are not coming to us. There are so many who are out there who are not coming. And bulk of the tertiary care essentially deals with failures down the line with improper or more often no management at the primary care level. Why I say this? Now, if many of these conditions are caught up, if the primary health care system is very robust, we wouldn't have so many patients at the tertiary care level. We would be preventing a lot of those just before they progress to the advanced stages. So we are still not there for various reasons. Also, this is just to show you what I mentioned earlier. The number that comes to us is very low in the bigger group of people. If you see, those who come to us is very few, and those who seek care, maybe not coming to you but going elsewhere. But those who don't seek care but need it is much, much bigger. I'm sure it is. I know that it's very difficult for the youngsters to understand what this means. If you look at the population-based studies, you will realize what I say about this. So who's responsible for those patients? How to create access to everyone who need care? Can technology help? We are in the era of digital health. I'm sure everybody understands artificial intelligence today. Just to give you a background on how telemedicine started in India way back in 2001, it was ISRO, the Indian Space Research Organization, which really put the seed for this by giving space time for many of us. This is one of the mobile vans we were using for screening for a condition called diabetic retinopathy. With a satellite antenna, our team would go into the community. The diabetic patients were pooled and their photos were taken and sent to us. And in the base hospital, somebody would read and send a report back. And this is how we were doing it for quite some time until technology improved. And today we don't need such huge satellites because there's a lot of cumbersome work that you need to prepare these sites when you go into the community. And today, as I said, the internet penetration if you look at from 2014 to 2024 today, it's grown anywhere from 14% to 52%, which is a huge leap. We all know that, and we are all experiencing it. I'm sure many of you can't even imagine the era when cell phones were not there. We all lived through that. We survived. But how we are using today, how do we use it in the interest of the growth of the community, of the society at large, is what we all have to put our mind to it. The Indian telemedicine market, especially after the COVID, really went huge, multitudes, like in thousands it increased. There were platforms like Proctor which reported a 600% increase in online consultations. The market size, the Indian telemedicine market value was valued approximately $1.8 billion in 2021, and this is expected to grow by 31% from 2022 to 27. It's rapidly increasing. If you see technology, I don't know, is there anybody here who doesn't carry a cell phone? I'll be really, really surprised. The government also understands this and has made tremendous effort, especially in the recent times. There's been a tremendous effort from the government side in improving the healthcare activities using technology. The e-Sanjeevani, many of you may have heard of it. is a platform that helps in online teleconsultations, connecting directly with the patients. Ayushman Bharat Digital Mission, the ABBA is another factor that is coming in, where every patient would get a health card number. So their entire health record is available in their hand. So every one of us is forced to use electronic medical records going forward. So just to share with you our own experience at iCare, we divide telemedicine in iCare as primary, secondary and tertiary. We have been doing this for quite some time. We started in 2004 what we call as primary eye care centers or vision centers for every 50,000 population. We put a low-cost eye care facility staffed by a trained ophthalmic technician with a link to the base hospital, which provides primary eye care. The technician is able to examine the patient just like a doctor would do when they come to the base hospital. And this is a video where the patient is going. She pays 20 rupees as a consultation fees, which is good for 3 visits or 3 months. So she gets a complete examination by this ophthalmic technician, including intraocular pressure measurement, taking a photograph of the back of the eye. And the entire data is entered into an electronic medical record. And then immediately they connect to the doctor who's sitting in the base hospital. And then the doctor is able to see the electronic medical record simultaneously, and then able to talk to the patient and tell them what the problem they have, what they should do. So today, if we see 100 patients, we are able to see 80% of them are disposed right there. Only 20% may need to be referred to the base hospital. So we have about 113 vision centers. We see about 3,000 patients a day through these teleconsultations through our multiple vision centers. So this is just the process that happens. So it's like a hub and spoke model. We have multiple tertiary hospitals. The Arvind Hospital is located in multiple larger cities, and they are like a hub with multiple spokes attached all around. These vision centers are the spokes, and when the patients need, they would be referred to that. So we have today 113. 2023 we had about close to almost 10 lakh patients were seen. And this has become a role model. We helped in setting up in Tripura about 40 vision centers in 2008. Today, even today they are running, and recently Chhattisgarh, Tamil Nadu and Bangladesh has started implementing vision centers in a large scale, and we are helping them to do that. So this is an era of digital health. Telemedicine applications are useful in healthcare delivery, health awareness, health education. Today we are also talking about tele-home healthcare for the aged population. This is available in the Western countries. It's yet to take up more in our countries, more so because of the inaccessible areas, especially in a state like Himachal, where you have a lot of areas where accessibility is a challenge. And I am working a lot on artificial intelligence. I use that in screening for diabetic retinopathy. We are hoping we can use this in triaging patients early on before they even get worse, and also triaging the patients so that the specialists need not screen patients. They can focus on dealing with patients who really have problems and work so that they are able to attend to more patients. And today, because of AI, in future we will be able to do customized healthcare is what people talk about. So this is just to give you a glimpse on what telemedicine, digital health and all that is about. You will be hearing more and more as time goes by. I'm sure every one of you will have an opportunity to deal with. I'm sure you're dealing with patients over phone. That itself is a telemedicine. But we need to have guidelines. Thankfully, the government of India has come out with telemedicine guidelines. And using this, I'm sure, going forward, we'll be able to provide much better health care to everyone who need, not just to the urban population or just those who can access care, but also those who cannot access care and reach them and help them. I want to thank you again, and thank you for this opportunity to share our thoughts with you. Thank you, sir.
Short, precise, and an enriching session by Sir. So your insights and expertise would definitely make a significant impact for the telemedicine. Sir has something great
thank you,
to
sir, for extending all the
reveal
cooperation for organizing this event. When they told me that
Okay, so that is Telemedicine Society of India. Sir would be doing it here and with our other dignitaries. Please.
all the more happy because we have all the youngsters here. Because you are the ones who have to know what's happening on this, because this is going to be.
Good evening to all of you. What we are doing here is releasing the newsletter of Telemedicine Society of India. This is an official release of the newsletter. This is not the first issue. The issue has been around since 2020, and it was a regional newsletter in Tamil Nadu chapter. And in January this year, we made this a national newsletter. We hope that in time this newsletter will become a journal, and this is a newsletter.
I would like to invite Dr. Professor Meenu Singh, but she'll be here with us in an online session. She's Executive Director, AIIMS Rishikesh, and immediate past President of Telemedicine Society of India. Please bear with us while we connect with her, our another keynote speaker. Good evening, ma'am. Can you hear us? Hello. Good evening, ma'am.
Good evening, can you hear me?
Yes, ma'am. Am I audible to you?
Yes.
A very good evening to you, ma'am. Though it's a virtual session, please accept my warmest greetings and please commence with your session.
So I'm not going to be using these slides for this session. They are meant for the panel discussion. I would, for the inaugural session, I would just make a few comments. Honorable President TSI, Dr. Kim, and the Principal of Medical College and a dear friend, Dr. Milab Sharma. I wonder if Director AIIMS Bilaspur is here, Professor Negi, and Kangra Vikrant, who's the organizer for this particular conference which is taking place. So I'm really thankful to, and I'm really happy that this is happening ultimately in Tanda Medical College. And this was something which we always dreamt that this would happen here. I'm very sorry I couldn't be here because of some work-related exigencies, but I'm really very happy to participate online. So note that Medical College, Dr. Rajendra Medical College Tanda is actually part of our National Medical Colleges network, and it's affiliated to the Regional Resource Center of PGI Chandigarh, which is again affiliated to the Government of India. And we have been doing some sessions earlier with PGI Chandigarh, which involved transmission of clinico-pathological conference, other sessions which were held, many other conferences which were shown online, and many teaching activities which have been going on there. Another area in which Himachal has really excelled in teleconsultations is creating a hub and spoke model for e-Sanjeevani, and we know that Medical College Shimla and Medical College Tanda are actually connected to health and wellness centers, which are now known as Arogya Mandirs, through the e-Sanjeevani 2.0, which is our standard teleconsultation platform of the Government of India, and millions of consultations have taken place on that particular platform. It was really very interesting to see teleophthalmology, as was shown by Dr. Kim in the Arvita Eye Care, and similar model actually can be developed in Himachal and for ophthalmology, because that is one specialty where telemedicine becomes a real boon for consulting patients. First, for detecting the causes of their impairment, and secondly, also offering some treatment which could be related to these patients. Another thing which we are very happy to learn about is that there are many advancements which are taking place, and artificial intelligence and the centers of excellence for artificial intelligence have been created. And one of them is at our AIIMS Rishikesh, where I am at present, and also at PGI Chandigarh, where telepathology is being taken up as to develop some tools on artificial intelligence, and whereas in AIIMS we are working on clinical decision support systems based on the hospital data which is available on electronic medical records. So I think it's become now very important for all the medical colleges to have an electronic medical record of all the patients, because to preserve the patient further use for developing tools using artificial intelligence. So I would request the principal of Dr. Rajendra Prasad Medical College as well as AIIMS Bilaspur to resort to that kind of
data maintenance, and so that we can collate most of this data later on and develop a diagnostic and a therapeutic plan for these patients in these areas. I'm working in Uttarakhand right now at AIIMS Rishikesh, and what I find is that the terrain and many other problems are quite similar to Himachal. And there are several interventions which can be popularized in Himachal, which we have been using here. And that includes drug delivery and many other products delivery using drones. And I'm very happy to say that drones have also started in AIIMS Bilaspur, and they must also be using them. So telemedicine these days is used not only for consultation, it is also used for triaging patients. It is, and that triaging leads to patient evacuation, treatment of patients from a remote end using mentoring, telementoring, and sometimes even surgeries like robot surgeries can be performed from a distance using various technologies which are coming up. So many other applications which have come into being and are being used by various startups is using robotics in healthcare, and their patient education is one thing, patient registration is another area where robots are being used, and we can cut short the lines which we usually see, the long lines which are there in front of registration counters. And as was being mentioned, that we have this Ayushman Bharat digital machine going on, under which we have Abha IDs. And I'm sure in medical college Tanda also they must be using QR code based registration for Abha IDs, because using this particular facility, patients can actually carry their records, their patient records, and these patient records can then be taken from one facility to another or from one state to another. And we know that Ayushman cards are now being used by most of the patients for their healthcare, and hence the availability of these health records across the country becomes very, very important. And it is not only that, one can also follow up these patients in the form of a cohort, and that becomes very, very effective in the case of children, where you can set them up right from birth and subsequent years using these health records, and you can collate data and again come out with several algorithms which could be used for management of these patients. So there are several applications, and I know that we are going to have a very interesting session after this inaugural session also, which is relating to these new technologies. So thank you very much for allowing me to participate online, and I would certainly be there listening to all the talks which go on. Thank you very much.
Thank you, ma'am, for being with us and helping us progress the session further. I would now like to invite Professor Dr. Uma Shankar to please come on the stage and hold the dais for distinctive talk on telemedicine practice guidelines. Sir is Managing Director, MedBot, and Honorary Secretary, Telemedicine Society of India. Your clap should not stop.
Good evening. Good evening, all. Hi. How's the Josh? Hi. Yes, it should be high. Okay. Firstly, I would like to thank the organizers for inviting me for this wonderful CME and giving me the topic, which is one of the most important topic for all telemedicine practitioners, that is the telemedicine practice guidelines. So let me keep it very short in the sense, not short like very short, but it will be lengthy short. Okay? So the session objective for the next 20 minutes would be, like I was talking about, the telemedicine practice guidelines, or why the telemedicine practice guidelines, the purpose, and then we'll talk about various tools of telemedicine applications, then what are the principles in telemedicine consultations, and there are different frameworks of telemedicine consultation. So we are going to discuss these 4. How many of you know about telemedicine over here? Hardly anybody. So this is the right time that you all should know, because you're all budding doctors. And in future, all of us are going to use telemedicine extensively. We are using now, even without knowing that it's a telemedicine, we have been practicing. Maybe at home you would have been giving some prescriptions over a phone or something like that. Today WhatsApp has become an important tool where we all give prescriptions. So we should know if we prescribe in these technology, what we need to do, what are the guidelines. So Government of India came up with this guideline called Telemedicine Practice Guidelines in March. They released in March 25th, 2020. Then later, it was just a guideline. Then later in 2023, it was gazetted, but due to some reasons, it was withdrawn. Okay, so that is, now we are using the telemedicine practice guidelines, which was released in 2020. So what I'm going to do is, I'm just going to give you a brief about what the telemedicine 2020 guidelines is. In some comparison, I would add what was there in the second guideline, that is in 2023. So it's now, the telemedicine practice guidelines was released by the Board of Governors, the MCI. Okay, and this is for the registered medical practitioners, that is the allopathic system of medicine. There are other system of medicine also have their own guidelines from the respective councils. So there's a disclaimer here, whatever I'm talking, this is for academic purpose only. Okay, it's about the guideline. It's not a law by themselves, or it's not a substitute for a professional legal opinion. So if you need any legal opinion, you need to consult your legal advisor. If you want further details of these guidelines, which is available in the document, so this is the link where you can go and get the guidelines in detail. So this practice guidelines is mainly governed by 5 laws, that is the Indian Medical Council Act, National Medical Commission Act, then Indian Council of Professional Conduct and Ethics Regulation 2002, Drugs and Cosmetic Act 1940, IT Act 2000 and 2011, and Clinical Establishment Act 2010. So these are the 5 major acts which this is governed. The purpose of this, why do we need this telemedicine practice guideline? So this gives a lot of advice to doctors that what services, how we have to do, what we have to do, especially in practice of telemedicine. So this assists the medical practitioner in pursuing the further course of action, what needs to be done for specific and safe medical practice. It helps to realize the potential of the technology completely. And there are guidelines how we have to practice, especially like informed consent, then continuity of care, medical records, reimbursement, and all those things. And it also provides all information related to the information technology, what are the platforms and how platforms to be used, and what guidelines we need to follow when we are going to use these platforms. Okay. So that's about what is the purpose of this guideline. And advantages, all of us know that it helps in the telemedicine in increasing the access to care. We have already been speaking about that. Then it saves cost and effective. It's very effective for remote and rural areas, and it can reduce the burden. The second, just now I spoke about that. So it enables what called the provider's safety, patient safety and wellness. So I will just skip the definitions. All of you all know about that. So what is this practitioners? Who can practice? According to this guidelines, a registered medical practitioner who is enrolled with the state or the Central Indian Medical Council, they are registered practitioner can practice this. So the scope of guidelines, it's meant for RMPs according to Indian Medical Council Act 1956, which covers the standards of RMPs to consult patients by telemedicine and all the channels, like what are the communication technologies which are there. The same thing is there with addition in the second one. Okay, so it says that the scope, along with it, should be used in conjunction with the other national laws, rules and regulations like clinical standards, protocols and policies and procedures. So this excludes, the guideline excludes the hardware, software, data management, the technology part of it, and the telehealth, especially the research and CME, continued medical education. And it does not provide consultation outside the jurisdiction of India. So this is only within India it can be provided. The second guidelines also talks the same, except that the last sentence is a little different. Who can provide consultation? A registered medical practitioner can provide consultation. He can use the telemedicine. There's nothing much difference. We have to follow the same guidelines what we follow in our in-person consultation. Except a little bit of caution we need to look into. After the first guideline, there were a lot of issues, there were a lot of questions asked. What if there were some issues? Who will be held responsible? Where do we have to go and complain? So the second guidelines came up with that, said that where the doctor, the practitioner is there, they have to complain to that particular state council. So what the government said, that within 3 years they will come out with the course, and then everybody, all the practitioners have to get this course done, and then they can practice online. So that is still going on. It is still not yet come, but organizations like us, the Telemedicine Society of India, we run this course and we also give a certificate where anybody wants to know can take it up. So what are the tools? Tools, any practitioner who wants to practice telemedicine, he can use any tools, like it can be as a telephone, as a video call, or a chat, or it could be a LAN connection, or it could be a data transmission through your email or a fax. Or there are a lot of apps now you have in mobile, or there are a lot of softwares. Any of these can be used. Irrespective of what tool, whatever communication used, the core principle of telemedicine practice remains the same. So based on the practice, there are 4 basic classification of telemedicine application, that is the classifications. The first one is based on the mode of communication, which is the video, the audio or text based. So video, you can use any video chats, or there are platforms, okay, and then text, what we already use. Then based on the timing of information, whether it is real time or asynchronous, that is what we call it as store and forward. So in real time, you can talk to the patient simultaneously, and in asynchronous, there is an exchange of information which it need not be always the patient and the doctor are together. The next one is the purpose of consultation, whether it is for emergency, whether it is non-emergency, or the first or the second consult. So depending on this, the classifications are there. Then the last one is based on the interaction between the persons, that is with whom. It's between the patient and the physician or the RMP, the caregiver and an RMP to an RMP, that could be a junior doctor to a senior doctor, or a specialist, or one specialist to another specialist, or a health worker to another registered medical practitioner. So these are the 4 basic classifications what we have. To practice this, there are 7 elements we have to consider before we start any teleconsultations. Very quickly, in very short, I'll tell you what are those. First, we have to look at the context. In what context are we going to do the teleconsultation? Next one is the identification of the patient and the registered medical practitioner. Then we have which mode of communication we are going to use. Then most important is we need to take the consent. Then which type of consultation are we going to do based on what we saw, the different types of consultation, that is the first consultation or second consultation, whatever. Once we do that, when we decide that, we have to evaluate the patient, whether the patient is suitable for doing a teleconsultation. After evaluation, then you can go for the patient management. So this is what we have to do before we start any consultation. This is the process, the 7 elements what are there. One by one, as I told you, the most important of all is, it is the practitioner who is going to decide what to be done. Okay, so the context. So the context is the RMP should decide whether it is his professional judgment to decide whether a patient who comes to him, or somebody who's asking him, whether that particular case can go, is it appropriate for a telemedicine consultation, or it needs an inpatient consultation. So based on his judgment, he can go ahead with that. Okay. So how do we do that? That's the first context. The second one is identification. When we do a teleconsultation, both the patient and the doctor have to identify themselves. The patient needs to know who the doctor is consulting to, and the doctor needs to know who is the patient he is consulting. Okay, so the doctor should verify, confirm the patient's identity by name, age, address, email, phone number, and all, because there could be possibilities of exchange, somebody else impersonation, something could happen. So it's better he has to confirm who is the patient. Similarly, the RMP should ensure that the patient credentials are also correct, details, and the patient should also be able to ensure the credentials of the doctor. Okay, so that is where we see how they both should be able to identify each other. Then, it is important that the registered medical practitioner should display his name, registration number, qualification, the state which he is registered, and what kind of communication. Whatever communication we are doing in that, it is mandatory that they have to display this. So the next one was the mode of communication. I told there are 3 modes of communication, primarily the text, audio, and the video. You can use any. It is left to the physician, the doctor, and the patient. Depending on what is available for them, they can choose whichever is available. It can be either real time or it can be forward. Okay. This is most important. This we generally do it, but when it comes to telemedicine consultation, it needs to be explicitly done. So there are 2 things. If the patient is initiating a teleconsult, so it is called as implied consent. If somebody else is initiating the teleconsult, so it is called as explicit consultation needs to be taken. So if patient is calling a doctor for teleconsultation, no need to take a separate consent. That is what it is said. But if it could be a health worker or it could be a caregiver or somebody who initiates the consult, then they need to take an explicit consult. Okay. So it can be, they have given a various form, it can be over recorded, it can be a photograph, they can sign what it is and they give consent, or it can be a video, it can be an audio, or there are various guidelines which is given by that. So whatever it is the responsibility of the practitioner to record the consent for all medical legal purposes. So there are more details in the telemedicine practice guidelines. The second one, I'm not going into detail, it's the same thing which is detailed more. So now once the consent is taken, they need to exchange information. The doctor has to evaluate the patient, whether the patient is suitable for the teleconsult or not. So it is his judgment whether it's a serious condition, it needs some procedures or which can be done in online or no, or he will decide on to that based on the history. So if he thinks that it cannot be done online or it can be done online but it needs a video consult, then he has to ask for a video consult. Okay, but for everything he has to maintain the record. Once he decides that, we go to the next one. It's called a teleconsultation. So it can be a first consult or it can be a follow-up consult. The first consult, according to this guidelines, it is the patient consulting with the RMP for the first time, or the patient has consulted with the RMP, but it is more than 6 months, the patient has not come back, or it may be for a different condition. So these 3 are the first consult. The follow-up consult is the patient has coming within 6 months, or it will not be considered follow-up consult if there are new symptoms, or the RMP does not remember for what this consultation was given. So that then it becomes a second consultation or follow-up consultation. So this is the process. Just quickly go through. The patient initiates a consult, so that becomes implied consent. Okay, so it could be either text, video, audio, then patient identification is done and physician identification is done. The physician checks for assessment whether it is fit for teleconsult, so quality. If it is not fit, it's an emergency, then he refers to the emergency. If no, then he assesses whether the evaluation can be done online. If it is yes, then appropriate consultation is done, and once it is done, if it is not possible to do teleconsult, then he has to refer. If it is yes, then he will take the case, whatever we do, then it could be prescription, it could be counseling, or it could be health education, anything can be done. So this is the process what we do in first consultation. Second consultation is the same, except that the last one, if it's a new complaint, then it goes as a new consult. So once the consultation is done, what we do is the patient management, either it could be health, education, counseling or medication. Now comes here, we have to be very careful when we are prescribing online. So via teleconsultation, you can prescribe, it's a discretion of the RMP. Everything is the same. Because he is accountable for that particular patient, so he has to take an extra care. Whatever medical condition, he has to first diagnose the condition and then prescribe. I'll give you how the guidelines are given, how to prescribe in this. Everything is same as an inpatient or in-person consultation. He can prescribe, but he has to decide only when he is satisfied that it can be done through telemedicine. Okay? So if he prescribes without diagnosing or without even provisional diagnosis, then that would be considered as professional misconduct. So there are some restrictions which cannot be done. So like you cannot prescribe Schedule X drugs, narcotics or psychotropic drugs. So whatever drugs are there, that will be issued by the government time to time. What can be prescribed? So list O drugs, that is over-the-counter drugs or the common drugs, list A drugs which they take regularly, or the list B drugs which they have been treating and for the follow-up cases or something. So when we issue a prescription and transmit, what needs to be done is they have to issue a prescription based on the guidelines. What we use in regular prescription in our in-person based on the regulations, the Drugs and Cosmetic Acts and rules. Okay. So in teleconsult, the prescription can be given either a photo, a scan copy, a digital copy of prescription, or the signed prescription, e-prescription can be done. Because now there are a lot of apps and platforms where they have this digital prescriptions available, so it can be done. Because today, nowadays there are a lot of platforms where they directly connect you to the pharmacy. If they want to connect or send the prescription directly to the pharmacy, what we have to do is the RMP has to take a separate informed consent so that he can send the prescription directly to the pharmacy of their choice. So delivery can be done anyway. So these, in the new guidelines, they have told that the prescription should have the name, qualification, registration number, address, all these things are, date and time should be must. So this is an example. I'm not going to go with this, the new one. So this is an example of how a prescription should be there. It has all the details. You should have the differential diagnosis, chief complaints, then you should have one thing which is important there is, apart from what, it should mention that this particular prescription is generated from teleconsultation. That is a must. So these are all, we follow whatever medical ethics and data privacy and confidentiality, that it's all common. The only thing we have to add is we have to look into the regulations of IT Act 2000 and 2011, data protection and privacy laws we need to look into. Sorry. Now, also we should also remember that there could be some breach which happens because of the platform. So if there is any breach of data sharing through the platform, in that particular situation, the RMP is not responsible or liable for that. But we should always, that is the reason the practitioner should always ensure whom they are going to hire or which platform they are going to use. Visit all the data protections are there or no. So misconduct, there are some of them are considered misconduct. So if a physician is insisting to a person or to the patient that you have to do a teleconsultation, no. For example, maybe they have given a target in that hospital that you need to do so many teleconsults. So, but the patient wants to come to the hospital in person, so the doctor cannot insist that you do a teleconsultation. So that is a misconduct. Okay. Or if the RMP is misusing the patient's data, it could be a photo, it could be their their patient details or something on social media. Nowadays, we see a lot of people sharing the cases on social media, but even the MCI or the NMC has put a lot of restrictions into that. Okay, so when we use telemedicine, you should not use the restricted drugs when you do teleprescription. Okay. And the most important is you should not solicit patients for telemedicine through any advertisements or something. Otherwise, all will be taken as penalties based on the AIIMS Act. The second most, because it's teleconsult, we should maintain all the data. We should maintain the data trails, the log, the patient record, what was done, if there is recorded some audio, video, all those records should be there based on the patient timestamp and the records. All documents should be maintained. Can we do it free? Can we charge? Yes, you can charge for teleconsultation as you do in normal in-person consultation, you can charge. Okay, whatever is your charge, it is left to you. You may decide what you want to, but you have to give a receipt for it. So there are a lot of ethical things in telemedicine, so you should respect the ethics, whatever ethics all of us have to follow. Then they say autonomy, the doctor has the autonomy, the doctor also has a privacy. So you should also remember that there are situations when patient may call you anytime because you have the mobile phone when you're traveling or in your personal time. But you have to ensure that what is your consulting time to the patient. Responsibility, it is the responsibility of the practicing physician or the consulting doctor to take care of that. We have to maintain the quality of care. So the details are there, I will not go because of paucity of time. The guiding principles, what they say is, it is a professional judgment of the practitioner to be decide on what he wants to do. Irrespective of which mode of treatment he can decide, the principle remains the same. It is his discretion to decide whether the case has to be in person or in teleconsult, what mode of communication needs to be done. He can choose not to proceed with the case if he wants to at any time. He may refer to an in-person consultation. Even if they are not able to, if some procedure or some examination needs to be done, the physician can refer to a nearby doctor, get the examination done, get the report done and give a prescription. That's also possible. Okay, and the patient also has the right to discontinue the teleconsultation. So that is what. So the framework, I'll not go into details of this. There are 5 categories of scenarios where teleconsult will happen. One is between the patient to and practitioner, caregiver to a practitioner, health worker to a practitioner, and RMPN to RMP, and in emergency situation. So these all, which we already saw, I'm not going to go into detail. I'll talk about the caregiver. So when a consultation is done by a caregiver, who is a caregiver? It could be a family member, or it could be any person, or it could be, for example, it could be an ASHA worker or someone who is doing this. Okay, so there are 2 possible settings when the caregiver we are giving. It could be either the patient is present with the caregiver or the patient is not present with the caregiver. If patient is present with the caregiver, then you can take the consent from them. If the patient is not present with the caregiver, there are 2 situations. If the patient is a minor, the patient is incapacitated, they are deemed to get, by default, they can take a consent. Okay, or the caregiver has already received an authorization letter from the patient, then they can go ahead. So again, with the health worker, it could be the patient should be present with the health worker. And again, it's the judgment of the health worker should judge whether it can go for teleconsult, which is possible or no, and then next by the doctor. And they have to obtain informed consent and then proceed further. Now this we generally do with a junior doctor or to a specialist or something, so that is there. But the responsibility lies with the treating physician. In emergency situation, again, it is the doctor who has to decide, because sometimes we may have to give the first aid and then send what needs to be done, so it can be done. In the interest of the patient, we can guide them what needs to be done, but don't treat all the emergency cases. It is for them till they go to the higher center. Okay. So in all emergency cases, we have to advise for in-person interaction. So now that was for all the physicians. Now there is, last one is for the technology platform, as it's an enabling. So this guidelines also gives instructions or guidelines for the technology platforms for enabling telemedicine. So these platforms should ensure that the consumers are consulting with the practitioners who are registered practitioners. So we should register only after due diligence. They have to ensure that if they take anybody, the doctor into their platform, they have to do complete due diligence whether they are qualified doctors or no. Okay, so for that, their qualification, their registration number, all should be displayed so that everybody gets. We should not use artificial intelligence for diagnosis purpose or for counseling or prescription or something, but you can use support for evaluation of the patient. Okay, it can be used. Okay. The company should ensure that if there is some query or if there is some problem, the patient has a right to give their grievances or queries, ask any queries, whatever. If there are issues, the platforms can be blacklisted. Now, ultimately, how do we avoid all the medical legal issues what comes when we are doing online practice? This is most important for all of us, so that how do we avoid this? First, identify the patient, identify the doctor, and with the patient you have to identify with the government authorized ID. So today you can ask for Aadhaar card or any ID proof whether it's a patient. Identify whether it's an emergency patient or no. If it's an emergency, try to refer. Diagnose properly and write the diagnosis before you prescribe. Okay. Follow whatever guidelines we saw for prescription. Don't prescribe all the drugs which are not supposed to be prescribed. Okay. Always maintain a copy. It may be a bulk, but it is always better to maintain a copy of your prescription in whatever form, either physical form or digital form. Do not share patient's data anywhere to anybody. And if there are legal issues will come mostly as similar as what we have in our in-person consultation, except for the technology, data privacy related things. So there are a lot of positive aspects. It's patient friendly, simple, very comprehensive. The most important it is the professional, the RMPs who decide what needs to be done. So they have the freedom. So any digital format they have given, the government has approved. It could be your WhatsApp, it could be your text messages, or it could be whatever, it is approved, so that it is not that it's only the platform or high end, where it can go even to the last mile connectivity, even the poorest of poor. Like as Sir was telling, everybody has a cell phone today. So everybody can use this technology. So then it can reach the rural areas. Most best, or it is very simple and very user-friendly guidelines, what we could say. Okay. So there is a shift, there is a game changer, this particular guidance, because earlier there were a lot of hesitant whether we can practice whether legally is permitted or no. So now after the guidelines have come, we can very confidently go and practice telemedicine. To conclude, I would like to say is capitalize on the potential of telemedicine. This is the solution which is going to be delivering the right healthcare, the right patient, the right time, the right practitioner. Any questions? I am ready to take any questions later. Thank you.
Thank you, sir, for such an enlightenment. We will now proceed with the next session, which holds Leveraging in AI Telemedicine, Global Best Practices and Applications for Remote Himalayan Regions. And this session is to be taken by Mr. Ajay Devisar. So I invite Mr. Ajay Devisar to please come on the stage and commence the session. Sir is healthcare AI strategies and an entrepreneur.
Thank you so much.
Thank you for your patience. We're just getting started. Can you tell me where is it? All right. So, hi everyone. Good evening. What an honor to be here today. While my team just sets it up, let me give you a good context of why we are here and why I'm here in particular. Very shortly worked across the world, Paris, US, Asia Pacific, on healthcare and technology. Finally, it's homecoming for me, coming back to India and bringing all the technology and knowledge here back with me to serve the country and many people who need facilities of healthcare today. I'm joined today by my colleague, Dr. Sachin Verma, who would be speaking on the panel shortly. But then one big question. While my PPT comes up, and I just heard that an AI bot has actually barged in and she wants to talk to you. So that AI bot is being chatted with my team. I think she wants to give a message and that's why the delay. What does she say? We'll see. Okay. So there's an AI chat bot she's got here, and let's see what she has to say. Now, how can a chatbot not be there in an AI conference? There we go. Perfect. Thank you. Can I put it in? Yes, I'll do it. Thank you. Okay, perfect. So that was the hitch, I guess. This chatbot wants to talk. Oh, okay. Really?
Good evening, doctors. I heard there's a conference on telemedicine happening here in Tanda. The news of this conference is making a buzz in the AI world. I must confess, I was hoping for an invitation, but it seems the algorithms didn't quite work in my favor. Nevertheless, I couldn't resist dropping by to say a quick hello. I hope you all have a fantastic time exploring the future of healthcare. Without further delay, over to you, Ajay.
Thank you. So can we
Good
give it to the
evening,
chatbot?
doctors. I heard there's a conference on telemedicine happening.
All right, there we go. So this chatbot is the future. Many times when I'm asked to speak on occasions like this, where I'm talking of AI mindset and healthcare AI, I send my avatar and not really attend the conference because that's the future, what is going to hold for us. We are all going to have our avatars and we are going to live into a hybrid world where our avatars would enable us, like Dr. Subramani very nicely said, and it's a very wonderful presentation. Thank you for all the insights. This is the future, sir. Okay, how many of us have used Paytm or UPI, Google Pay? All of us, right? So we now transact not just by currency. How do we talk to friends? Not just telephone. WhatsApp, Snapchat. We have loads and loads of avenues to talk to our friends. Am I right? Back there, right? I can see raise of hands. So what is happening? We are becoming residents of a different world. What is that world? Okay, let's see. We make payments by gateways, right? There are payment gateways. We cannot afford but change today because the other person on the other end is asking us to pay by UPI. We are interacting with others on different platforms. Now, what is the store? Are we aware? Most of us might be that there are medical services gateways already in existence. I've had the occasion to work with Johns Hopkins for quite a number of years. For 10 years, I was handling HCL Healthcare for technology with NHS UK. Medical services gateways are surrounding us, and we cannot afford to be an island of seclusion in the environment which is changing around us. Am I right, sir? Right? We have to get in the rhythm of the environment. So that's why we are here today to talk of telehealth services. So what is the new world all about? The new world, here are three categories I'll give you. The new world is about being connected. Aren't we all connected all the time? The answer is yes. We are moving to a connected world. What is the second one? We are moving to a collaborative world. Collaborative. What is this? This is a collaboration of minds. People from different streams and different knowledge repositories have come today. They're collaborating to up the game of telemedicine. And Tanda, the government college Tanda, RPGMS has taken the initiative, but collaborative. We saw some people joining us from Rishikesh. What is the third one? We are moving into an insightful, data-driven world. So what does it change for you and me? The change is going to hit us faster. It is already hitting us faster. How does it change for you and us? We have to get ready. We have to get ready, and we have shown the world that we are ready. When COVID came, the mankind proved we are ready for it, and we've made it a way of our life. So that is where, in this context, telehealth services are today positioned. So when I came back here 6 years ago, I had the occasion of meeting Dr. Sachin Verma, who will talk to you soon, and we said, okay, let's just put into practice what the regulatory, what the academicians and what professors and experts are talking about telehealth services. I'm going to dive deeply right away into a demo of the product as to how does it happen in reality. Interested? Shall we go there? I'll run a video for you, which is a screen recording of how it actually works. How it works between the center, intelligence center, with ICU on wheels. The ambulances, we worked into a lot of cases where the first time response in US, when the ambulance reaches the patient, that's the most critical time, I understand from my medical fraternity colleagues, to diagnose and do something about it. So ambulance on wheels, ICU on wheels. We have primary care centers, home centers, and secondary care hospitals. Sitting here, this place can become the node and hub for enabling and empowering many zonal hospitals around us, right? Let me just play a video without much ado about what it is all about. Let me go there. Can I have the video, please? Thank you. All right. So what you see here, thank you. Thanks for that channel. So ladies and gentlemen, what you see here is, I'm from Budget ICU, India's largest and fastest growing ICU network today. We are today running 20 ICUs through telehealth services. And as we speak, we are adding 5 ICUs month on month. Thanks, Gujjal. So we are adding 5 ICUs month on month. So by the turn of 15th of August, we are looking at about 50 ICUs under our belt. Now, what have we gained from this? What have we learned from it? I'm here to talk to you, even after my talk, over dinner, over a cup of coffee, as to how it is actually done. We have put 2 demonstrations in the day-to-day in 2 of the departments at your college. We've put some equipment in the ICUs. We've spoken to a few doctors. Some of them are here in the audience. We've demonstrated to them, to the nurses, chalta kaise hai, how does it work? So there are 3 components to it. Essentially, simplifying it for you. 3 components. First component you see is a tab which goes into the ICU. Into the ICU room. This tab is for the person who's in charge of the ICU, a senior resident or whoever is the officer there, and nurses. On this tab, like my fellow colleague Dr. Subramaniam said, we enter the patient with all the precautions, as you said, of identity and privacy, and all these norms are taken care of. We enter the patient here, and there's a secure login. This login is absolutely secure. Now let me tell you a very interesting insight. Do you know hackers around the world are trying to constantly hack every application, every website, and every system, digital system you might have in your pockets. They're trying to hack it. How do we counter that? We have something called VAPT, a penetration test. This application complies with topmost penetration tests. Hackers cannot hack it. Okay? We have a login. Then after the login, you put a password. You can see we have put 2 cameras into your 2 of the ICUs, pediatrics and the neuro. These are actual pictures before, and you will see we not put any patient here. So what you see is, as you're in charge of the ICUs, let's say you are looking at 4 or 5 ICUs within your department, you get a live feed of what's happening there. So it becomes your extended eyes. Mind you, this is not being recorded. This is not being recorded. This is just extending your vision into the room, giving you the power, and this is how many hospitals worldwide are already doing it. So you get to look at the hospitals. Now, we have added just 2, you can add as many as you like. In fact, today I went to a server room here. I don't know how many of you have seen the data science room. You have a, hey, thanks. Okay. I think some glitch here. So while you look at it, I went to the data center and there's a big screen here on which you already have 25 cameras. So I was talking to my colleagues that if you have 100 ICUs on 4 screens, you can look at all of them as to what is happening. And what does AI do for me? In those ICUs where you define that some parameter is out of range, it will club them all together into one screen of, let's say, red, amber, green. We all familiar with red, amber, green? So it will say this is red cases, amber which are likely to become red, and these are green. So by exception, like Dr. Subramaniam said, AI will augment you in working and controlling it better. So this is how it works. You have a visuals of what's happening in the ICUs. Then what happens after that is you can chat live with the person. Now this is where collaboration comes into play. Let's the person in charge of the ICU or the nurse has put into chat some condition on which he wants some advice, right? Lot of people who are logged into the system, the doctor, the consultant, are all on the same chat. This chat we have devised on the same platforms as you are familiar with WhatsApp chat. In fact, it's much more powerful than that. Much more collaborative and powerful because this is the input we got from these 20 of ICUs who are chatting constantly day in and day out and giving us feedbacks. This product therefore matured. We have our own proprietary chat, totally secure, and what AI can do, whatever documents you put, it will create a copy and a secure copy, right? Okay, so you have a chat. You also have a function whereby you can go and look at the details of the camera angle. You can zoom in, you can change the camera angle, simple buttons. So I told you 2 components, the camera in the ICU, an iPad in the ICU, and there's one app on the doctor's phones. Sitting at your home, a wonderful thing can happen. Let's say you have 100 patients in the ICU, and now you want to be alerted when something goes wrong with 5 or 6 of them who cross a certain parameter. Right, sir? Let's say SpO2. The saturation goes beyond a certain level. You want to be informed irrespective of whether your staff is looking at it or not. Only in those cases where SpO2 goes a certain level below, you will get a notification on your phone. So on your phone, when the notification comes, you can click on it, look at the chart, day chart of the patient as to how the notification has changed. I'll just show it to you. So this is the camera angle. You're changing the camera angle. You can see how smoothly it can zoom. You can go into bed-wise details. On the right, you can click at bed 1, bed 2, bed 3. It can zoom into that bed in particular. This is the chart I'm talking of. This chart can be filled in 2 ways. Manually by the staff, or it can be picked up directly from the machine. We're living in the age of IoMT, Internet of Medical Devices, right? Medical things, IoMD. So this chart can be manually filled, which we feel is the right way because on the monitors, 5 para monitor, etc., you may not have all the things you want, and this is how I've been advised by my doctor team, the domain experts. We have a chart which the team fills, and in this chart you can assess day-wise what is happening, patient-wise what is happening. Okay. Now, let me show you one more feature here. The history of all the records is maintained. What happened, like you said, we have to consider it as if it's an actual concentration. All the records are automatically maintained for you. Data trends, discharge, chats, notifications is what I was talking to about. Now, this is the nurse tab. This is your login. You pick up the ICU UR. There are notifications for the nurse. There are notifications for the staff managing the ICU. We go further. And now, you can see you can add patients, you can view all patients, you can do a lot of things. Simple interface, nothing technological about it. Okay. On the left hand side, you see all the patients which are looking. Add a new patient, all the details like you said, sir. Upload the picture of a document. Just click and the camera comes alive. Here, you're clicking a picture. You click the picture, upload it. Select the document type, PDF, Excel, whatever. Then you can view the uploaded document, right? All right, so the document has been uploaded. Now, you want to look at the vital sheet. So you get a day summary. This is where, ladies and gentlemen, I was telling you, have you heard of edge computing? What is happening here, sir, is when the internet is down, edge computing is saying the machine or the tab is so intelligent that it acts on its own, and then the moment it finds the internet connection, one of the challenges we found while working was very poor internet connection. In fact, we had a lot of trouble into remote areas where internet is not there. This machine can take care of it. So edge computing, this machine is able to take care of poor internets. You feed in a temperature here. Firstly, you saw it being fed as 98. The moment it fed 102, there's a red alert here. You can customize these alerts, sir. You can say 102, 104, or whatever you want in different parameters you define. Different parameters, pulse rate, blood pressure, you define the parameters, AI will give you alerts. Now what happens to this alert? The moment a figure like this is given, higher temperature, BP is, heart rate is normal, or if it increases, then the moment this data is submitted, very simple to change, you can change these parameters. These records start getting stabilized for trending. You can see what's the trend of my patient. Okay. In US, what we did was, we had a county level hospitals. All hospitals came together and the trend was mapped at the state level. So trending can be done at the state level also. Okay, now what is happening is, this is the notification, friends, I told you about the doctor. So this is the doctor application. The moment the temperature or heart rate or blood pressure went out of order, you're getting a notification on your phone. This is management by exception. The consultants, senior HODs and experts don't have time to look at all the patients all the time. You can set triggers. The moment a trigger sits up, it will give you a notification. What do you do with the notification? You click the notification and you get a list of all notifications. Click on the most recent one and you can see where is the notification coming from, bed number, patient number, and so on and so on. Just a few examples of AI making your life much easier, augmenting you with data, augmenting you with more power, making it easy, collaborative, and totally location independent. So this is what the product does. I won't go into much details. I have loads and loads of it, maybe a few slides here. Then I will tell you more about something very interesting. Okay, this is how you have trends. Now, not only the central monitoring station which I showed you, which is the resident officer or the senior resident looking into all the beds, the consultant or experts from their phone can, if needed be, look into the patient. This can zoom in to the monitor and you can look at the ECG. This can zoom into the drip and see what's the drip rate. This can zoom really deep because it has a 25x zooming power and absolute clarity. We demonstrated that today to your fellow colleagues and doctors and nurses in the morning today. We had a good demonstration. So what is happening now? The in charge of ICU, the doctor, everybody is able to collaborate real time. As you can see, the zoom power, it can go right up to very, very granular level and see what exactly is happening. Again, you have notifications. You can, from the phone, extract the document which the nurse had fed in, right? This is the same document which we fed in from the tab. And this is the chat where you are chatting with everybody in a collaborative manner. You click a picture, load it up, and chat with everyone. This chat maintains the name of the person who's chatting and who's logged in. So, ladies and gentlemen, that's the future for us. Thank you for your patience and time. Before I end my session, I hope you had a good glimpse of what the product can do. I've just put a few screens here. 3 principles. Keep it very simple. Very, very simple. Don't complex, because this is for remote users in far-flung areas. They are not comfortable with technology and more complex system. I can see some heads nodding here, right? Secondly, keep it very intuitive. It's very easy to learn this in a few hours and implement it. Third, make it so secure, so technologically advanced that this can integrate with whatever medical services network and gateways are going to arise very easily. And this comes from about 25 years of experience. I worked with a lot of global companies. We've put all that technology in here. Okay. This was the glimpse of the product. We are running a demo outside in the lobby for any one of you to come here and look into details of what else this has to offer. Before I go, I know I'm just about at the end of my time. 3 myths I want to burst with today. Myth number 1. This invades my privacy. The answer is, thank you ma'am, it actually strengthens it. Because the kind of principles and regimes you have to adhere to, this is more secure for maintaining the privacy. I told you, these are just eyes and ears. This is not recording anything. Secondly, the data is anonymized. The data is scrambled. Okay, even if I want to look at the data, we worked a lot with RBI, with Visa, American Express banks, Credit Suisse First Boston Bank, all this critical data of US Treasury, they're all anonymized, and that's how we work. Same technology has gone in here. Second myth, sir. This is insecure. So the answer is, this is more secure. Because a piece of paper can still find its way into hands of some people, but something as secure as this can never be compromised. And that's what we are here. Blockchain is all about. You heard of blockchain? You heard of blockchain? What happens in blockchain? We create so many copies of something, right? Not the data, but the electronic printing that nobody can fiddle with it. And that's how NFTs were born. You might have heard NFTs just went to the roof in valuation. Blockchain technology makes it much more secure than anything else. And you know, most of the world exchanges, currency exchanges are moving to blockchain. So is the medical services gateways. This is all blockchain based. And lastly, it's very difficult to implement. I think that's the myth, hardly needs to be busted. If people in rural areas of Punjab and Himachal, where 20 ICUs are operating in our own state, they are easily able to adopt it and work and take advantage of it. It's as easy, probably easier than learning how to do WhatsApp. So ladies and gentlemen, with that, I would take any questions you have. Very happy to answer on any views or ideas you have on this subject. I hope you liked it. Thank you very much. Any questions, ma'am? Any question? It will help the audience. Anyone who has any questions, sir. Sir. Sir, the cost, as you know, we've kept the name as budget ICU. The cost is very, very minimal, sir. It is sub 2 lakh rupees for a basic unit, sir. It's modular as you add more units, but for most of the cases, like ours, it can go as sub 2 lakhs to up to 15, 20, 25 lakhs. But it's very, very reasonably priced, sir. That's for the system, sir. And that's the mission, sir, actually. Thank you for asking that question. The mission, me and Dr. Sachin have said is, we want to do something. We want to break the price barrier and disrupt the market, right? And hence we boldly put our name out there, Budget ICU. So that's our brand promise, that we will be at the rock bottom of the price with the topmost medical protocol-based quality treatment. So thanks for that question, sir. All right, gentlemen, ladies, see you soon after the talk. Thank you very much. Have a good day.
Thank you for such an enlightened talk, sir. Your efforts are indeed commendable. Now, most awaited, we are going to commence with the panel discussion with the topic Remote Care in Remote Regions, Advancing Telemedicine in India's Mountains. So for this, I would like to invite Dr. Sunil Shroff, our guest of honor. Sir, please come on the stage. He's Managing Trustee, Mohan Foundation, and Vice President, Telemedicine Society of India.
Good evening. I hope you're all enjoying this session on telemedicine. I just wanted to ask, how many of you are students here? Can you raise your hands? Students? Okay, great. Many of you. And how many are faculty? Of course, rest are faculty, I suppose. And how many are from Himachal Pradesh chapter of Telemedicine Society of India? Can you raise your hands, please? This side? Few. I hope that next time when you come, all those people will raise their hand, all, including the students. We have student membership as well in Telemedicine Society. So I do hope that we can have more of you joining us as we go forward. You heard 2-3 lectures before me. Remember that telemedicine is just a tool. It's not going to replace you. It's a very powerful tool. And you need to learn how to use it judiciously to your advantage. So if you don't learn how to use it, you'll probably, can I just open my slides? You'll be at a disadvantage. Use it for education, use it for research, use it for teleconsultation, use it for diagnosis. So you can use it for multiple areas. And as students, as you go forward, in 5-10 years' time, when you go out there, a lot of technology will be there available to you, you know. And people who will succeed will be the ones who use this technology very judiciously. You heard the Budget ICU gentleman speak to you about how you can bring remote care at a very affordable cost. The problem in India is that access and affordability are two big issues. And telemedicine will help access and affordability, especially for a country with 1.4 billion population, where majority of people, 70% of people, live in rural areas, who don't have access to tertiary care, who can't afford tertiary care. And as doctors, we have a responsibility for everybody. And remember one thing, if we are able to bring a good template in India, then the rest of the world, developing world, which forms 80% of the world population of 7 billion people, also benefit. And those solutions will come from countries like us. For the 80% population, 5 billion population will benefit if we in India are able to bring some tools of success and show some tools of success. So let's go to the panel discussion. Very apt. This paradise called Himachal Pradesh. And I'm delighted to be here. Just open My slides. Thank you. This is the curtain raiser to the main conference, which is happening in November. Sometimes, technology takes a little bit of time to get warmed up, and that's what it's taking. No, never mind. Yeah, thank you. So I'm a urologist and a transplant surgeon. I'm the vice president of this society, August Society called Telemedicine Society. I do a lot of work with organ donation, and I'm managing trustee of an NGO called Mohan. No financial disclosures, disclaimers. This is our panel. We have 8 speakers. 1 has dropped out, so we'll have 7. And we'll have Dr. Meenu Singh again join us from remote. And remember one thing, as I said, telemedicine is just a tool. It doesn't change our ethics of medical practice. The same ethics follow. It is just a support system, as I said. You heard this telemedicine, then you heard that telehealth, and then you heard digital health. They all mean the same, more or less. But the terminologies have changed over the years. We started with telemedicine. It was one-to-one, patient to doctor care. And that started way back in 1875 when Graham Bell invented the telephone. From that time, doctors have been giving teleconsultations on the phone. So it was one-to-one. And then, but 25, 30 years back, we started using the same technology for education, research, and teleconsultation. So it became, the medicine term was dropped and health was introduced and called telehealth. And then came in 10 years, we've had 5G come, we have Internet of Things, we have artificial intelligence. So we have widened the scope of using technology, and that's why we dropped the term tele itself and brought digital instead. So it became digital health. And that's the brief story of telemedicine to digital health. Remember that. What has changed also is the rising incidence of lifestyle diseases like diabetes, hypertension. From treatment, we're talking about prevention. From illness, we're talking about wellness. And also we're talking about the government of India is pushing for universal healthcare, and with new technologies like AI, artificial intelligence, Internet of Things, we brought digital health forward. The COVID-19 pandemic actually, the lockdown accelerated the adoption of our digital technology, and teleconsultations became more acceptable. India did the highest number of teleconsultations in the world during COVID, by the way. And then in COVID, we did contact tracing, we did triage, vaccination status. I don't think so we would have got over COVID if we didn't use technology. And COVID was a virus, of course, and sometimes you need a common enemy to unite the humanity. But it also magnified our disparities and heightened our interdependence on as humanity, because what we learned from here was duplicated somewhere else. We are doing contact tracing and so on. Yes, I know. And this gadget, as Dr. Uma Shankar showed, was passed. And these were notified, and these are here to stay. As TSI, Telemedicine Society of India, we brought this report in the 2020 conference in Chennai of how teleconsultations were happening in India. And what we found was that growth of teleconsultations was, doctors were mostly from tier 1 and 2 cities, patients were mostly from tier 2, 3 cities, smaller towns. And there was spurt of teleconsultation from rural areas, and women consulting first time were increasing in numbers, and so was people over 50 years of age. So ladies and gentlemen, teleconsultation is here to stay. What the new norm is hybrid form of care, where you go and see a doctor and your follow-up advice can be on teleconsultation, especially in a region like this, where many of your patients are coming from smaller villages. And most of us have, this device called the cell phone, the smartphone, which is a very powerful device. It has, everything in it. It has, it has camera, it has GPS, it can do multiple things, it can monitor patients. So you all have this powerful device, and it's going to bring out the revolution. The government of India spending on health also is increasing. GDP is going to be 2.5% by 2025. Ayushman Bharat, wellness centers, primary health centers, e-Sanjeevani, you heard, and so on. As I said, the smartphone price has been phenomenal. In 2019, there were only about 480 smartphones. In 5 years, the number of smartphones today we have in this country is more than 1 billion. So this powerful device is really going to revolutionize healthcare. The cost of 1 GB data in India is 33 times cheaper than what it is in the US. It just costs rupees 13, 1 GB data in India. And the payment gateways have been a revolution in India. We are the country which does the maximum number of transactions as far as payment gateways is concerned, more than China and other countries. The Ayushman Bharat is here to stay. The government of India has a huge vision with Ayushman Bharat, so everybody is insured. And we also have the Aadhaar card, the health ID card, and all this is going to be a game changer. So you are in exciting times, and as young graduates, I'm sure you will be using technology. And Dr. Uma Shankar has already given you a talk on what the guidelines are. The government of India wants you to be familiar with the guidelines to use teleconsultations for teleconsultations. So going to our panel, we are going to be having about 6 speakers now. 2 have dropped out. And we have a very powerful panel here. We have Colonel Rita Dhadwal. She's a veteran. She has served the army. And she's an anesthetist and critical care. She also is part of the Telemedicine Society of India Himachal Pradesh chapter. So she is going to do our first talk. And then Dr. Vikrant was supposed to be here from AIIMS, but he's not able to make it. So Dr. Rita will give a little bit of overview of his talk. And then we have Dr. Rajesh Guleri. He's the Chief Medical Officer of Kangra. And he passes MBBS from AIIMS Simla. And he has masters in epidemiology. He also has a Scotch Award on telemedicine projects. Then we'll have Dr. Ashutosh Guleri who will be talking. Can I just invite all my panelists to come on the dais, perhaps? Dr. Rita, Dr. Rajesh, can you just slowly walk to the dais so that we can all have you here? It'll be easier, it'll save us time. Then we have Dr. R.K. Abrol, Professor Department of, is he here? Ashutosh is not able to be. Dr. Abrol is Professor Department of Surgery from your own medical college in Tanda. Please, sir. Then we have Dr. Vani Sharma. She is a gynecologist and she's going to give her perspective. And then we have Dr. Sachin Verma, who is going to talk on AI. And Dr. Amit Verma is going to talk about challenges in remote mountainous regions. Can I just invite you, madam, to start your talk? Do you have a hand mic? Can you give me 1 or 2 hand mics, please? Can you get her talk on? Yeah, this will give. Madam, I think you have some slides, so you can present it from here. Please. Can you please somebody speak here, please, so that we can just change the slides as they come. So we are hoping that
Good evening, everyone. So, as Dr. Sunil Shroff has said, I'm the opening batsman. We are going to talk about challenges to telemedicine in remote and mountainous regions. when we spoke about this subject, I mentioned to Dr. Shroff that this is just the right place to come and apply telemedicine here, because we only have very rudiments of telemedicine. One public-private partnership with Apollo, which Dr. Guleri would be elaborating on, the government initiatives. And the place is fertile and ripe for implementing the technology of telemedicine. The youngsters who are sitting here will one day be using all this very conveniently. And but for the moment, I'm going to talk about the challenges which the state faces in healthcare, and how telemedicine would be beneficial, would be covered by the rest of the speakers. So first of all, there is a geographical isolation in the mountains. Accessibility is a problem. Inclement weather roads which are not accessible, steep gradients, landslides, all this makes an impact on reaching the health facility for medical care, and it can have an unfortunate end and not the result which you want. Timely emergency response is also difficult. The population is scattered, so the government has to make facilities which may not be adequate, but that happens because you go long distances. They can make so many healthcare facilities, so healthcare facilities also are at great distances. You have to travel and reach those, get medical care. The infrastructure is poor. Roads and transportation is expensive to maintain, expensive to make, and telecommunication fixed lines adequate. The companies don't want to invest in that, and internet is unreliable. Amenities like water, electricity are also not consistent, and this is a major challenge in establishing facilities and in maintaining healthcare. Now, the healthcare facilities are also limited because there's a necessity of hospitals and clinics. So when you have to travel long distances, the access is very difficult. Those facilities are overcrowded because they are few and far between, and that leads to a lot of, you can't give adequate time to the patient who has come from very far, and there's a resource strain, difficult to staff those places. Qualified people don't want to stay there, and well, so all that lack of staff, all that creates a situation where patients have a lot of waiting time, and they may not even be able to reach on time, or they're not even seen on time or seen adequately, given adequate time during a consultation. The staffing issues I've already touched. Specialist availability, pediatricians, anesthetists, surgeons, those services are not readily available, and even to train and recruit people and retain them there is a challenge. Road construction, vehicle wear and tear, fuel expenses. So all this accounts for limited public transport, and then the user is left to use private vehicles which are very costly. The medical logistics are compromised. Supply chain, how to maintain a supply chain for vaccines and other drugs which need, a temperature, secure temperature to throughout their before they are used in the lifespan. The storage, preservation. So all these things, it pushes up the costs. You have to invest extra to maintain, inverters and generators in your facility so that your medical equipment functions properly, your vaccines and medicines are stored adequately. So all these things are very challenging in these areas, and this leads to delay in treatment, reduced preventive care, so that even diseases which can be, many diseases, they remain undiagnosed because there's inadequate screening and vaccinations are not done on time. So preventable diseases also are much more. There is a health disparity between urban and rural areas because of this issue, and the scarce health workforce, affordability, all the extra medical costs are passed on to the patient. So affordability also becomes an issue, and resource allocation is also inefficient because the resources will be applied for urgent and immediate treatment and not for long-term and preventive care. Services are not available of specialists, and so people have to travel long distances just to get specialist services. So all these are the challenges of medical cover, healthcare in the mountains. Yes, telemedicine is a beacon, it is a light at the end of the tunnel, and in time to come, all this technology which Mr. Ajay Deva sir has also spoken about would help to reach the healthcare in a more user-friendly manner to the rural and far-flung areas. And also, as Dr. Shroff said, that we now use it also for education and research. If the internet is reliable, the doctors, young doctors who manage peripheral clinics, they could stay there and carry on their postgraduate classes online instead of, coming down to major cities, abandoning their posts to study for their post-graduation. They can consult super specialists for any problem which they have in the areas. I remember that when I was in a field hospital, I used the rudiments of telemedicine. We had MI cases, interpreted the ECG, rang up the specialist, asked him, this is an MI, so what to do? And he guided, okay, thrombolize the patient. So you can do that if you have telemedicine and reliable networks. So that's.
Thank you. Thank you, Dr. I think this picture of access, affordability being there is universal. As I said, it's not only here, it happens in 80% of the countries in the world. And I think, as you said, towards the end, telemedicine is a beacon of hope. And it's not the light at the end of the tunnel. The light is already there, according to us. Look at what happened in COVID. We used it extensively, and I'm sure Himachal used it as well, like other parts of the country. And we couldn't have got over COVID without telehealth, application of telehealth. So, when you, as I said, when you have a common enemy, it unites you. And it showed us the way forward, didn't it? I'm sure, I don't know if you used it for also doing, examination. In your postgraduate or, this one, did you use technology to conduct an actual examination? Not of patients, to examine a student, to pass the student. AIIMS did it. Many parts of the country did it, many medical colleges. I don't know if Tanda did it here, but that was quite effective. And we moved forward. So the technology is here. Dr. Vikrant is not here, and he was going to talk about these advanced technologies, wasn't he? So let's move forward with Dr. Rajesh Puleri. He's going to talk about partnerships and collaborations, which is so important in this field, because all stakeholders need to get together, and then only we can get a bigger kind of solution to our problems. So Dr. Rajesh, you're on.
Good evening all. Dignitaries on the dais, off the dais. First of all, let me express my most sincere gratitude to the Himachal chapter of Telemedicine Society of India to give me an opportunity to be amongst such an elite gathering of speakers and panelists. I am no expert in this domain, but I'll just try to give you an overview and share what has been done in a limited way in Himachal over these years in telemedicine. Given the brief experience and knowledge I had while I was working during the implementation of these projects as the state node officer. So, primarily, we have 3-4 interventions in telemedicine. The journey started in 2015-16 to be practical. We were having a limited telemedicine network established through CDAC in 2013, but that did not work and did not yield the desired results. Seeing this, in 2015, we started a network with PPP mode and with the Apollo Tele network, and we were working with Dr. K. Ganpati, who visited our state also personally many times. Then there was a project through Piramal Swasthya for a limited specialty, and now we have e-Sanjeevani at 2 levels. So the Apollo Telemedicine project was with a specific objective to give access to specialist healthcare and super specialist healthcare to the remotest locations which were off-bound normally, and those times most of the year they were not reachable through road. So either airlifting was an option. So with identifying these 4 locations in 2015-16, 2 locations were started, DH Kelong and CHC Kaza, and then 2 locations were added in 2018. These were in the district Chamba, Bharmor and Pangi. So this was aimed at providing round-the-clock specialty and super specialty backup for the patients from Apollo Tele Network hub. So basically, Apollo came in, established the hub. The major challenge was ensuring connectivity at those times. So we had to install dedicated VSATs, and most of the cost of the project went into funding the connectivity costs. Apollo also provided paramedic support. They trained people for 3 months, and they trained our doctors also at Apollo Chennai and Hyderabad. And after that, we initiated. This gives access to more than 20 specialties and super specialty access. Till now, more than 32,000 consultations have been done, and about 1,400 out of them have been tele-emergencies. Operational cost is about 40 lakhs per annum for one location, and which is very reasonable, seeing that we would not have got even one specialist posted there for this cost. Second was the limited specialty network established in 2017 through Piramal Swasthya. This was to cater to the needs for 3 specialties: OBG, pediatrics, medicine, and this was to cater to entire state. This continued till last year, but now after this stabilization of e-Sanjeevani, this has been presently discontinued. So now e-Sanjeevani is at 2 levels. One is from a community health officer to the nearest medical officer, the basic teleconsult. It is a facilitated consult to the CHO to the medical officer. The second level is from the peripheral medical college, peripheral health institution to the medical college. So there are 2 hubs, AIIMS and Tanda. Till now, the uptake has been good. About 60,000 consults were done last year, out of which 55,000 were from level 1 and about 5,500 at level 2. But as normally happen in any government intervention, there are many constraints, bottlenecks, which I think I should be highlighting also. First is that mostly in the government sector, there is lack of ownership. There is not much felt need from the actual user. So it is more of incentive-driven, target-driven approach. CH has a target. The CH to do so much of teleconsultation in a month to get her performance incentive. Why it should have been otherwise? Like many medical students are sitting, and there has been so much discussion over the benefits of having telemedicine networks. So I think in coming times, people will see the added value addition like these interventions. There is a limited issue which I have had to discuss also. The names are being solved now also. At times there is, due to the busy schedule of clinicians, the availability of specialists is not there. There's a regular complaint from the medical office, and the patient or the beneficiary would not wait for your teleconsultation. So by the time you get connected, the patient leaves. So that is one of the things, and there are few internet connectivity issues. But I feel that in spite of all these operational challenges, as Madam said, there is a beacon of hope, and I think there is a very big scope in coming years for, especially for the state like Himachal, where we have geographical constraints, and I think in coming times we'll be fully utilized. Thank you so much. Thank you.
Thank you. Thank you so much. I think, these problems over the years will get ironed out. Getting specialists who are not coming on time, patient waiting. I think instead of buying one, you could have multiple specialists, more collaborations, and that challenge can be overcome. I mean, as far as partnerships are concerned, you had Dr. Kim from AIIMS Hospital, who has, I think, done so many partnerships in so many states. And, so I don't see why one partnership can be extended to Himachal as well for eye care. Because I think Arvind has been the granddad of eye care in the country now, isn't it, Dr. Kim? You want to say something quickly? I know you did elaborate on this a little bit in your talk, but do you see an opportunity in Himachal?
Definitely, this is a place which really needs something, telemedicine for sure. And there are so many organizations which are, we just need to find the right place, right interest, and I'm sure scaling up those efforts is much. As you mentioned, one of the things is the interest, the ownership in getting that done is the most important thing. We really have to drive our vision centers to, otherwise it wouldn't work. Because at the top level it is being pushed. So you really need that ownership among the people who are implementing these vision centers, these telemedicine centers.
And I think one step, what is required by the government to be more proactive towards good public-private partnerships. I think that will also help a lot. I want to invite Dr. Meenu Singh. Would she come online? On
Yes,
policy
sir,
and
there
regulation?
is some technical glitch. We are trying to fix it.
So then we'll go on to the next speaker. Yeah, without wasting time, since we are running a little late. What are you saying, Monica?
So actually, because of some technical error, Dr. Meenu Singh is not with us, so we'll just need 2 minutes to connect her.
Yeah, sure. But do you want to connect to the background while we take another speaker?
No, sir, just wait for 2 minutes.
You want us to wait for 2 minutes?
It's already done.
You're already connected. So just patience, yeah. We can take some questions if you want in between. Anybody from the audience wants to say anything? Yes, come forward, introduce yourself. Oh yes, we have the gentleman who talked on AI. Yes? Sorry, I didn't catch your name. Ajay, of course, sorry. Ajay, what did you want to say?
So my thoughts were ignited by Dr. Saab, the CMO. So very well said that more of an ownership of meeting the targets. It should actually be, as you very rightly said, done in spirit of service, right, sir? I wanted to get some more insights of how this shaped out, because that's what we are trying to do as a mission, to at a country level, state level, do the groundwork. So any advice from you, sir, for us as to what are the learnings for us to... Yeah, sure.
Meenu Singh is online now. Dr. Meenu Singh, welcome. I don't need to introduce you, you already been introduced earlier. So please talk about regulations, policies, and your experience from, you've been with Telemedicine Society for a very long time, you've been practicing the technology as well, so please share your ideas with us.
Dr. Meenu Singh is with us. I would like to request ma'am to please start.
So thank you very much. So as you know, I am now in Rishikesh, and I was at PGI for a pretty long time, and we had our first department of telemedicine, which was set up there and looked after for about 20 years in PGI, the telemedicine services, and we had our regional center, we said, and I'm going to present to you today a few stories. Something which we have been doing in AIIMS Rishikesh since I joined about 2 years back. When I joined, actually, AIIMS Rishikesh was emerging from the COVID and the post-COVID effects. And during COVID, a lot of recent evening consultations had been done there, although we did not have a separate telemedicine department, which we set up there. And we set up all the facilities. And somewhere in November 22, can I have the next slide, please? We had an offer from Tabasna, which is the Lal Bahadur Shastri Academy in Missouri, which looks after the IAS officers, that they wanted to develop a consultation platform, which was inaugurated by the Honorable President here, and we started doing consultations. After that, we had consultation with Ramakrishna Mission in Haridwar, and also in many hospitals in the periphery of Uttarakhand, which was Burdwar is one place, which is near Lansdowne, and then there is a huge network of Swami Vivekananda Health Mission at the hospitals that we started doing our consultations. And what we found was that people who are very receptive to this, video calls, and E-Sanjeevani 2.0 had just been introduced at that time. So we also set up some health ATMs in many of these centers, and these health ATMs are something which do point of care testing for patients who have been who attend there, and they even give a body analysis, give all the biochemical parameters, which are sent along with the consultation to the consulting doctor, and you can make the decisions. Along with that, we set up several follow-up clinics because after the patients are discharged from the hospital, it is very difficult for them to report back to the facility because of the difficult terrain there, and it really takes a very long time for patients to come. So we started these tele-follow-up clinics, which are a huge success, and many of our consultants or faculty, which includes many surgical disciplines like cardiovascular sciences or neurology or neurosurgery, they started using it. Another very important service that we have in Rishikesh is that of tele-ambulance service. And as you all know, there was a tunnel collapse recently in the Silkyara tunnel where the road was being built, and 41 laborers got trapped in that. It was at that time Delhi consultation facility was set up for them using a camera, which was a fiber optic. Through the fiber optic cable, it was taken into the tunnel, and patients, or in fact all those laborers, were suffering from a little bit of psychological problems. They were feeling very insecure whether. So those kind of consultations were them at that particular period. And all 41 of them were brought to AIIMS. We have a helipad, and we have this heli ambulance service to AIIMS, which is the first AIIMS of the country. And all these patients came to us, and we looked after them. They were more or less okay. one patient who was having a atrial septal defect, which was treated. Now, we also introduced drone services in Pradesh because this is something which supplements telemedicine. We get a call from, there are several accidents and disasters which keep happening in the Himalayan state. And many times these patients get consulted, they are teletracked using mobile phones or even telephone calls and using, of course, the local peripheral health services. These patients are looked after, and then some of them who require some emergency